While we're kind of getting set up, I think we'd all like to thank Community First for Randy Kuahar and everybody else for all the effort that they put into doing this. And for those of us, at least on the Big Island, Community First has been, really kind of a congealing presence for all of us and a true ally in trying to improve access to care. And so thank you very much to Community First. So we'll be chatting today about some of the challenges we have in the state of Hawaii. They were discussed by the Congresswoman and by Dr. Lewin and others, and we're pretty familiar with this. In terms of my background, I was a commander in the Navy and married a local girl who was a nurse in Hilo, and we moved back there back in 1993. And it's been a wild ride, but I never dreamed that it would have the level of challenges that it does, practicing here on the Big Island. On the Big Island, we've kind of had been practicing an environment of scarcity for doctors, nurses, dentists, other healthcare workers, not for weeks, not for months, not for years, but for decades. And we've come to a point now where I think there's a lot of focus, tremendous appreciation for Mayor Mitch Ross's support, and from our Big Island lawmakers. In particular, I think it was very well, much appreciated and very well deserved when at the end of the session last year, the legislature and Governor Green pointed out the leadership of Senator San Benaventura and Senator Noy in passing key legislation that's going to help, I think, improve our workplace environment and the ability of practice to succeed in Hawaii. With that said, I thought we'd do, first of all, we've just got a lot of expertise on the stage, is to give everybody 5 or 10 minutes to discuss for our panelists about what their experiences are and what they see the challenges are, and what might be some of the legislative solutions that will be helpful in addressing those challenges. And then once we kind of give everybody a chance to go through what their thoughts are, we'll pick some individual topics and get down to the weeds on in those discussions.
Okay, thank you very much, Scott. Thank you, Community First, for arranging this great conference. I appreciate it very much. So I'm Gary Okamoto. I'm an MD. Prior to joining the Loa Care about 12 years ago, I had a full practice in hospital-based medical rehabilitation. So my payer mix, just FYI, was Medicare, Medicaid, and no pay. So it just seemed somewhat congruent with my past when I was offered the opportunity to get involved with managed care. And believe me, for the first 2 years, I thought it was one of the worst career decisions I've ever made until I began to understand how much impact our state Medicaid program has on the people of Hawaii, and how so many individuals, from babies to kapuna, are on the Medicaid program in Hawaii. So it's very, very meaningful to me. Specifically, the issue I've been asked to address is prior authorization. And as some of you may be following this issue, in 2024, the state legislature passed a resolution to have the Legislative Reference Bureau to study this issue of prior authorizations, its reform, and the timely service that's rendered by providers both at the acute care hospital level, but as well as post-acute care. And the Legislative Reference Bureau is expected to probably interview a number of you as major stakeholders, especially being on Hawaii Island, and to report back to it, I presume in 2025, and thereby give their recommendations. Just also for you to know that there are probably more than 17 states, probably more than 20 now, that have enacted legislation. Don't know if every one of those bills had passed those states, to codify prior authorizations, to set up the guardrails and the purpose of prior authorizations. And a similar attempt is being made in the state of Hawaii. And I expect something to happen in 2025, if not 2026. Having said that, the CMS, the Centers for Medicare and Medicaid Services, has already promulgated its CMS final rule, which articulates very clearly that by 2027, there needs to be in place prior authorization programs by health plans with certain goals that I think are really quite admirable, which I want to share with you. One of the goals is to make sure that in this process, that the patient, the provider, and the payers are all talking to each other in a bidirectional manner. And they emphasize the critical importance of having application programming interfaces that by that time should enable providers, payers, and patients to speak to each other so that it's clearly transparent and real time when decisions are made, especially if they're adverse, but also what the appeal process is, and of course, what everyone wants to know, has the recommendation made by my provider been approved and done again in a timely manner? I think that if I were to just quickly add to this legislative concern over prior authorizations, which I can make more explicit if you wish, is the importance of having information technology. I think you heard Jack Lewin and Judy Moore Peterson and even Eric Schell mention something about that. It's critically important in the payer world right now. We're largely driven by claims. Claims may be as old as 3, 4, 5 months. What we need almost real time is clinical data. And that will provide the kind of information and analysis for us to make wise decisions on a more real-time basis. So having said that, let me pass it on.
So thank you, Doctor. I'm Senator Joy San Buenaventura. I'm State Senate Chair of Health and Human Services, which basically means that all health and human services issues that hit the state, including Department of Health's budget, and I see Dr. Jack Lewin there smiling at me, his budget, as well as human services budget, HHSC, go through me. Okay, of course, I'm not the final say, but I have an input on it. The chair's position, in case you folks are not aware, is pretty big in that because a lot of the health issues and a number of bills go through me, I have the ability to kill bills as well as support them. And so in SB 1035, which Dr. Goskertz got Senator Inouye to introduce, came through my committee because I was a solo practitioner before I'm a solo practice attorney before I became a legislator, and my sister is an MD practicing in Arizona. She's a Concentra person. Anyway, I was fully aware as a solo practitioner about the problems with the general excise tax. And I was fully also aware because I was Human Services Chair and as a state representative about how there was very little Medicaid doctors accepting Medicaid, Medicare, and TRICARE because the reimbursement rates were low. And basically, we were punishing them for taking these cases because we're charging them GE tax, which according to state law, they're allowed to pass, but because federal law prevents them from passing it on, they're actually being penalized. And so when Dr. San comes to me and advocates for Medicaid dental, and when I know that there is this huge shortage of dental, it's very difficult to recruit when we're telling them we're gonna be punishing you 4% and a low reimbursement rate for this. So it was easy for me to pass it on. But in order to support, that's one of the powers of the chair. If anybody, and I know Dr. Sand has gotten, Dr. Lewin has gone through my committees, I am super efficient. People think that I don't know what the heck I'm doing because you are limited to 1 minute, right? I cut you off. But I'm fair about it. I tell you, you have 1 minute. If you don't wrap it up within 1 minute, you're basically talking yourself against your position, okay? So you got 1 minute, you gotta have your written testimony in, and when the general excise tax bill came to me, I wanted to hear all of the tax bills that go through my committee. And one of the powers of, like I said, of the chair is to kill or pass before it goes on to WHAM. WAM or the Finance Committee doesn't get to hear any of the bills that I kill. So since I really wanted the 1035 bill to pass, I killed a number of general excise tax bills that came through. You folks who have ever been in my committee have seen, I go through 15 bills. I have these advocates screaming at me, well, what about the child care tax credit? What about this? What about the family leave tax credit? I felt because of the medical shortage and because no general excise tax exemption bill has ever passed, we needed to have the full support of the legislator towards this. And to me, we need to support our healthcare workers. We can't just tell them that we support you and not back it up. So I get the brickbats. Like I said, there are people screaming at me that their favorite bills have died. I get, of course, my advocates like Scott Gertzkos, Dr. Sand, who say, thank you very much for listening to us and knowing our plight. But anyway, that's basically the power of the chair. The second thing I was told specifically to talk about the good jobs bill monies. The good jobs monies is really federal monies. Okay, it doesn't come through the state. So I actually had to go research it because I thought it was a hele imua. We really want to. Let me just give a broad. You folks know we have a healthcare shortage, workers, right? Everybody knows in the state we have a healthcare shortage problem. What you folks don't realize is that we are pumping out a lot of graduates. Okay, a lot of them are actually being hired. We have backlogs in DCCA regarding certifying and licensing. They're saying they have a 400% increase in applications. We can't seem to approve them fast enough. That's why I really feel for the Kapiolani nurses, there isn't enough. We're not licensing them fast enough. People come to me and they say, well, why don't we pass the interstate compact bill? If you folks, like I said, the people who study legislative bills that go through the Senate know I am a prime advocate of those interstate compacts. If you look at all the interstate compacts bill, you will see my signature as the primary introducer in all of them. I kill them because we don't have the capacity, we don't have the manpower, we don't have the IT right now to even process the ones we actually do have. I'm hoping, I don't see Lauren Kim here, he walked out, but he's the government relations person for oh, there he is. He is gonna hear me out as to seeing whether or not there's a way we can have, at least for healthcare, certifications and licensing be under Department of Health instead of DCCA. Well, thank you. Okay. No, and because if we really want to tackle it, we need to have healthcare professionals look at these application forms and let's go pump them out. Let's go get them certified. Let's go get them licensed before we create more licenses. There are all these community healthcare workers who want me to. Judy left. I was bending her ear on this too. Whether or not we can go get them licensed. But if we don't have the ability to license people, it doesn't really matter whether or not I pass the bill. It's not gonna happen. And that's what I keep telling all these advocates. If you don't work with the boots on the ground, it doesn't really matter whether or not we pass anything because they're not going to have the workforce to be able to process these applications. And I really feel for the birth workers who need certifications for midwifery. We don't have any certifiers here in the state. We have huge problems regarding certification and licensing. We are trying to get, last time I was here, I talked to you folks about initiatives, about the loan program repayment, which Governor Green has announced just recently what we have done. We're getting them more. We just got to get it licensed. Okay. I'm going to pass it on. Now you know the problems I'm looking at. I see the problem. I hope that there's a solution. I'm hoping for really a workaround. The solution, I mean, that is frankly the solo practitioner attorney in me trying to find other ways to get around what the roadblock is. And I am glad that the Department of Health is going to be on my side to hopefully one of the ways to get around, because what I see as one of the workforce shortage is not only just certification, but we also need to start licensing paraprofessionals, because we can't seem to pump them out of medical schools fast enough to fix the shortages. And you folks are seeing the effects of that. You're seeing the COVID shots and vaccine shots being done by pharmacist students and the like, right? You're seeing more dental hygienists being able to do more work. You're seeing PAs, nurse practitioners being able to have more authority. So that way we have the doctors being able to actually do, more doctor work rather than hand-holding. And I'm really hoping that we can get community health workers who do the vitals. That is time and money that we don't need MDs to do, because, same thing with phlebotomists and the like. And I'm looking at that as far as certification, as far as licensing, so that hopefully we can have the healthcare coverage we need for our island. Thank you.
Hello, I'm Esther Smith, and founder of Mohala Health, and currently the medical director of Kau Hospital. I think I'd like to go through our issues in the form of a patient's story. He's allowed me to talk about this. About 3 years ago, this patient came in with kind of vague pelvic pain and had like microscopic hematuria, like just blood that you couldn't even see in his urine, but it was there. And in a place where there hadn't been decades of underpayment of providers, I could have at that point just referred him to the urologist to figure out what the workup should be, minimizing the number of tests, getting him to whatever he needed quickly. But in that year, we had one urologist for most of this coast. And so if you wanted to get your patient seen, you had to prove that they really needed to get seen. So you start that process. Well, part of that process is getting imaging. And I'm very grateful to my colleagues at HRA, but they can only do so much. And frankly, we have a lot of equipment breakdowns because underpayment results in equipment that doesn't get updated. And so I don't know how many times various kinds of imaging haven't been available. But the first thing I have to consider is what form of health insurance does my patient have? Because that's going to determine what kind of imaging I can get and how fast. Now you might think, well, if it's an emergency, you mark the order stat and then the patient should get seen right away. Well, sometimes that doesn't work, because if you mark a patient as being stat, it's either 4 or 7 days to get that study done before the authorization disappears. And so what if the wait for the MRI is 2 weeks and you have a stat authorization that's good for half of that time? And so sometimes maybe you order the ultrasound first, even though you know it's not the correct test, because at least you have something. And so we get the ultrasound, and it's not very impressive. Some time goes by, the patient's frustrated. We treat it as a possible infection, because what else are we going to do? And he comes back, and he's more uncomfortable. And maybe I have to get a prior authorization to get his pain medication. They like to talk about the software and how it's going to solve everything, but every Sunday afternoon, I sit at my computer and do prior authorizations. The program works so that you submit and you ask for clinical questions, And sometimes they come right back. And sometimes they come back at a random time. Regardless of when they come back, you have to have them returned in 72 hours. And that inconsistency means you miss a lot of deadlines and you have to start over again. Also, that means you have a low success rate that is documented on your records, which means you're never going to be in the gold card program that's going to excuse you from prior authorizations. So back to my patient and the frustration and the trying to say that he's sick enough. The MRI shows that he actually has a thickened bladder. Kind of nonspecific. If he had a big mass, front of the line. If he had a big, super high PSA, front of the line. Nope, microscopic hematuria, thickened bladder. You could wait. And part of this is the patient, because with frustration and being like, why I can't wait 6 months and stepping out of line and what, I think it was over a year before he finally got to see the urologist. And I'm not blaming them. I am recognizing there are far too few of them because we're funded so poorly. But they finally get it, and he has metastatic bladder cancer. And they fly him to Oahu, where he finally gets surgery. And the hospitalist who takes care of him, and I've been a hospitalist, so I don't hold it against them, writes in the note, patient care delayed because his primary care physician treated this hematuria like an infection. So he's doing a little bit better, but he's not curable now. And so all of this just goes to like how practicing here is not like practicing somewhere else, and how the dysfunction at different levels all combine to cause us to have these worse cancer outcomes. It's why we have so many people who are having cardiac arrests, because like it's hard to get them through their studies. We have skin cancers that go farther because the patients don't want to have to fly to Oahu, where you lose an entire day and maybe you need to work to support your family. So the thing I ask overall with everything we're doing is that we stop trying to apply urban mainland solutions to our rural Hawaiian healthcare.
Hi, Kohi Dang Akion. I think I know a lot of you guys. That actually was kind of a good transition to me, because I believe that's probably what many of you guys have been hearing is my priority. So I'm a physician. I was part of the first class from Hilo Medical Center, so family medicine, stayed on island, and eventually evolved. Yeah, I've evolved over time. In this iteration that I'm in, I'm a private practice physician. I own Kohala Coast Urgent Care. We actually are on the 6th floor here. And then many of you guys heard about me because I reached out and established a branch of our urgent care on Molokai. So I would say I, against the advice of all of my advisors and my mentors, stay very actively involved in all the policy talks, because what we realize is by virtue of our job and what Dr. Smith just described, it's like it's impossible. Our job is impossible. It's so busy that we're often not at the table. So it's not because they don't want to be, but they just don't have enough time. When during the pandemic, I was one of the little guys, right? We were saying, hey, listen, when we're saying that there's no infections in Molokai or in Ka'u, we have to make sure that that's because we actually tested, not because we're not looking. So we went out of our way and thought of very kind of innovative ways to make sure that everybody got access to resources. That has been the number one thing driving me to this day is access to good care, because we've done a lot to try and talk about things, but access to care has always been the thing. And what a lot of the physicians all agree is if we just focus on that, we focus on patient care, it's really, really hard to divide us and be like, oh, this is just the doctors being difficult again. So one, for me, it's access. So all of the policy things that we look at, whether it is increasing the amount of reimbursements, just the level, so that practices like mine, Dr. Smith and Dr. Kurhara, all the people that I have served alongside, they need to get adequate payment for the care that they're giving and not lose money. This would then increase the amount of providers available to our Medicaid, Medicare folks, right? So that's access to care. It's stuff that, takes the pressure off of us as we're serving. So the GE tax exemption. And then now that I'm my own practice, right? So I can tell you, I have a dedicated staff member just on prior auths. One of kind of like the dirty secrets of rural health is, they've made do for long periods of time with a lot less. So the care of I gotta say, I'm like really proud of the kind of care that we provide on the Big Island, on in these situations, because having trained at Pittsburgh, I can tell you what it was like to be surrounded by colleagues and like be able to call right down the road. I'm texting, like we can talk about neurosurgery and like get them on the schedule. That is impossible here. So the people that are providing care in places like where we are doing it under significantly more stark circumstances. They're like kind of, where they're doing more with less. And progressively over the course of time since we did a needs assessment, or like I kind of did I created a training curriculum for community health workers back in 2004. So in the 20 years since then, the amount of providers, the amount of services has dwindled big time. So not just on, out here, but even in Honolulu. So a lot of our providers have left. Over time, our specialists have gone away. Our primary care providers have either joined practices and then kind of retired, or in the case of Molokai, which was one very, very marked example of what's happening in the rural health field, right? People died, retired, moved on, closed practices. And so like abruptly we're seeing these loss, like just serial loss. So I think if I can say what my priority would be, and what you will always see me fighting to be at the table for, it's access to care. It is supporting workforce development in two ways. We have to make sure that we're not losing more people. We have to make sure. So the GE tax exemption for one, right? When it was kind of turfed to 2026, that was somewhat of a death kiss to a lot of practices that are teetering on the edge of survival. So when we're looking at things that are well-intentioned, I think a lot of the people in this room, you guys have the ears of a lot of powerful people, or you yourself are very powerful people. Just really realizing that like the good intention has to be paired with good execution. So when we're, we want to do GE tax exemption, it'll help the practices stop being penalized for accepting patients that need the care. These are our most vulnerable populations. These are the people who cannot advocate for themselves. They need the care the most. Providers need it the most too, right? We need to be able to care for them. But when we finally, thanks to the senators, we made it over that hurdle. And then your very, very tired physicians are then told, it'll start in 2026. I can't even explain to you the amount of because we made it, but we didn't. So sorry that I know we'll probably talk more. You can ask me about stuff, but access, workforce development, and that means not losing anymore, but also minding that we do have a lot of people that want to join or want to practice. We have to, make it better so that they can actually practice in Hawaii. And then from the prior auth perspective, I can tell you just kind of lowering the burden that's on these few remaining struggling groups. Because I'll tell you that the direct impact is exactly what Dr. Smith has said. People are dying, people are suffering, and families are kind of like, they're taking on the burden more than we care to see. And I'm sure a lot of you guys have family members who have gone through it. We can do better. We have to make sure that physicians stay alive, and that we encourage them to be at the table to talk to you guys, so that the data and we're making decisions based on good data, on real data, real practice, real issues, because I think a lot of people are well-meaning, but we can't really do very well if we're not being mindful, right, of kind of the impact. So, sorry, that's my piece.
I got bucked off a horse last night, so I'm going to stand up a little bit and kind of get the crinks out. I almost became a consumer of orthopedic care there for a bit. So basically, we all know we've got this huge shortage of doctors, nurses, dentists, and healthcare providers. And our hospitals are really struggling too. 67% of our rural hospitals in Hawaii are at financial risk, according to a national survey, which is the highest in the country. And having served as chief of the medical staff at Hilo Medical Center for a period of time, the hospitals are trying to do the best they can with limited resources as well. So we're in this period, prolonged period where we've got a shortage of providers. We're starting to take some action at the federal and the state level to try to provide more providers through expansion of the medical schools and the nursing schools, the compacts that hopefully will allow other providers to come to Hawaii, although it also makes it easier for Hawaii providers to go the other direction. So it just means we kind of got to up our game here as well. And one of the things that Kelly Withy and the Area Health Education Center at the University of Hawaii does, they've done surveys, and they've asked providers, what are the main challenges? What are your concerns about keeping your medical practice open? And the number 3 concern they had was that the Hawaii's unique taxation of Medicare, Medicaid, and TRICARE patients that providers pay for. We're the only state in the nation that does that, and that practice will stop on January 1st, 2026, in large part thanks to Senator San Bonaventura here. The second problem was the low reimbursements that Jack Lewin talked about, compared to the rest of the country, particularly with our high costs. But the number 1 concern was administrative burdens. So there's a couple different things that are a problem when you don't have a high level of productivity from your small number of providers. One is there's lots of people that need care and they can't get care. And what happens if you don't have a healthcare provider, a primary care person, and you've got diabetes or hypertension or a neglected cancer? Well, you end up in the emergency room. And then by the time you get through the emergency room, you may need to be hospitalized, and that's going to raise the costs of care, as I'm sure Gary would acknowledge, by a factor of, could be 8 or 10 or 12 times higher. So one of the things that we can do to address the administrative burden is to address this issue of prior authorization. And I'll kind of, we'll get into a more in the weeds conversation of this, because this is important to a lot of providers right now. First of all, Eric Schell pointed out today that you really have to be highly productive, because of the low reimbursements and the high costs just to stay in business. And if your productivity is limited by the prior authorization process, so you're only 80% or 75 or 65% as productive as you can be, financially you're at risk of going out of business. And the other issue, of course, if you could be seeing 40 patients that day, but because of prior authorization issues, you're only seeing 28 or 32, those people are not going to receive care. So really the low-hanging fruit here is great. Let's train more people. Let's recruit more people. Let's retain more people. But let's get our existing providers as productive as they can be. And the American Medical Association has been fighting hard for prior authorization. They've got a website that you can go to, but I'll just try to summarize some of their findings. One is they found that providers on the average were spending at least 12 hours a week with prior authorization, and about half the folks are spending between 10 and 20 hours a week. And a lot of practices have actually hired people that they often don't have the budget for just to do prior authorization. The other concerns were that a lot of, at least on the provider side, it's felt that the cost of prior authorization are pretty high. They're high for the provider, they're high for the patient, and they also may be high for the society, since the cost of administering these programs through vendors and things like that can be quite expensive. About 25% of the providers knew of patients that had an adverse outcome, as documented by severe permanent disability, patient death, because of prior authorization delays. And then there was a very low confidence that the prior authorization rules that were out there that they had to comply with were evidence-based. And I can give an example just from my recollection and experience. In 2016, there was a period where basically outpatient cardiology and outpatient radiology imaging had just come to a standstill. There was a mainland prior authorization program that went into effect, and basically was you couldn't you couldn't get advanced imaging studies from cardiology or radiology in the outpatient world without waiting many weeks, and often they were denied. As a result, patients flooded the emergency rooms, which was a big problem in the state. There was a bill that was introduced by the Hawaii Medical Association, said, listen, we're having adverse outcomes. And if people can't get the care they need and they have a bad outcome, their response, of course, is turn around and sue the healthcare provider or perhaps the hospital, to make up for their injury. And that bill would have said, rather than the providers who had recommended a course of therapy or treatment or medication being held responsible, perhaps it should be, the insurance companies for having these mandates. And that bill did not pass, but it did result in a significant conversation between the insurance industry and the providers, where a much more reasonable level of oversight in the prior authorization was put into place. And I think we're at the point now too where prior authorization, and I don't prescribe drugs as a radiologist, but from what I'm hearing from our members is, on the task force, is that, whether you're going for physical therapy or surgery or want to prescribe a course of medical treatment, it's just the prior authorization burden has gotten to the point. I won't name one physician that I've got a lot of respect for who left a job as a professor at a prestigious East Coast university, came back to Hawaii to care for the community. And she's got kids. And, I kept getting these emails and stuff from 2 a.m. from her. And I'm going, what are you doing, a night shift or something? And no, she was, going to work, working a, 10, 12-hour day, coming home, spending some time with her kids, putting them to bed. And then she was working until 2 a.m, filling out charts for the electronic medical record and working on prior authorization, things like that. And that's just a burnout. A lot of us kind of remember, at least in the old days, that medical school was like a year without sleep. And that was followed by a residency program with a bit more sleep, but not enough. And for a lot of folks out there in the community right now, particularly in primary care, they are, you drive home at 8 or 10 o'clock at night and you see the lights on in their medical offices, and they're still doing charting and noting. So this is just a huge concern, and we need to address it. And I know that there's always a time schedule for legislative issues and things like that, but as I shared with the Congresswoman, this is something that is a priority that needs to be solved now, particularly for the health professional shortage areas, which encompasses the entire state basically, except for Honolulu. A health professional shortage area for primary care is defined as when you have more than 3,500 person per primary care person, per primary care provider. So we have in Hawaii, 35.7% of our population is in these primary or health professional shortage areas. And that's 500,000 of our population. That far and away exceeds the rest of the U.S. The next closest is Wyoming, and that's because they're a big, wide open state with a lot of counties with very few people. And there's a lot of states that have 0 to 1 to 2% of their population that are in these health professional shortage areas. So we're a unique place. You cannot get into your car and drive to the next city, the next state to seek care if you can't get care locally. Many of our local folks here basically in a position where you're trying to decide if you can, pay the rent or pay for your mortgage, feed your kids, or whether you can get on an airplane, fly over to Oahu, get an Uber, go over to, to see your healthcare provider, and then repeat the whole process. Sometimes if you got chronic disease or something that, like cancer treatments, repeatedly, it'll just break your budget. So we, as in pointed out, we're in a very unique situation here. In Hawaii, we've got a tradition of working together to find solutions. And that's why we're glad the senators here, and that we've got, we've got ongoing conversations with some of our colleagues and other folks in the healthcare industry. But this is something I think that needs legislation personally. There's a lot of public service announcements that go out about, the need to obey, to drive safely and not drink and drive or drive empowered or don't text while you're on the phone. But we still have laws. We have traffic laws that require that mandate that. Because it's not just enough to ask the population, to behave. You have to sometimes have these rules in place, these laws in place. And if you didn't have the traffic laws, the speed limits, et cetera, we'd have a much higher traffic mortality rate. We could be looking at dozens, maybe hundreds of more deaths on Hawaii roads every year. But because of the provider shortage, I would argue we have at least that many deaths because people have a lack of access to care. I was visiting a family friend on the Hamakua area a week or so ago, and that person shared that his spouse had developed a malignancy, and that her oncologist on the Big Island, unfortunately, was quit, or it was no longer available, and it was going to take 8 to 10 weeks to get a PET scan in Honolulu before they could start therapy. So he just actually sent out an email to hundreds of people, including me on the list, but they made the decision basically to leave the state and go to a major cancer center in California to seek care. So they're going to leave the state for a prolonged period of time, unfortunately. And then unfortunately, I heard that same cancer specialty hospital was just hit by cyber criminals and got shut down, at least in good part. So, in this kind of a story, you could probably talk to 1,000 people every year on the Big Island that have that. And statewide, you're talking about thousands of people that have this type of experience. And so, at this point, I'd like to open it up to the audience a little bit. We'll talk about some solutions that could be sought to help address this, but we have some folks that have got experience with prior authorization that you could share how that's impacted you or your patients. Yes. And if people just want to walk up to the front, that'd be perfectly fine too.
While you were talking, I just realized there's a big topic that doesn't come up in these discussions that I've been in, at least, and that's network adequacy. The insurance companies are collecting money every month from people, consumers, who can't access the service they paid for.
That actually was what I was gonna, because you think about like Molokai, they're paying the same premium for Kaiser and they cannot access anything from drugs to imaging to labs. It is complete BS.
Exactly. So people on Big Island, on Maui, who have to pay to travel, are paying the same premium as people who live in Honolulu who can walk down the street and get the service. Now, is that a physician problem? Is that the Maui physician's problem? That we can't take care of more people for less money? Because there are physicians, there are PCPs on Maui who have 3,800 patients on their panel. They can't see all those people and take care of them to the level that they want to, and to the level that they're paying the same premium to HMSA as the person who lives in Honolulu. We need to flip the question. It is a state mandate that the insurance companies provide network adequacy. Where's the insurance commissioner?
No, you're right, because I think that was one of the big things with the MedQuest too, right? Because they get assigned these PCPs. So when we were doing street medicine, we did this for a couple years. All those people were assigned PCPs. And a lot of them, majority of them, had never seen that PCP. The PCP wasn't aware or couldn't accommodate them. And so what we're talking about a lot of times with big groups, right, is that we have such good insurance rates. Hawaii is, it's one of those kind of smoke and mirrors thing. Almost all of us have insurance, but when you truly drill down to who has access to their primary care, even some of us who have really good insurance, I cannot see my own PCP. Like I cannot, like a lot of my physician friends are leaving because they cannot get a PCP. So the gap, the perception gap, like what you're saying. So a lot of us in the room, you're well-intentioned, like, oh no, but our insurance rates, like 98% of people are insured. But when you drill down, and especially in pockets for rural areas, Waimea, Konaka'a, South Kona, Ka'u, the true access to care is about 30%. And that is completely not the physician. So this isn't like something that like prior auth will help. This is literally, I think, one of the, and I don't know exactly how to do this, right? But putting the impetus back on the insurance companies. If you're going to insure these people, but you cannot ensure that they can see all these specialists or they have adequate network of providers, that should be on you, not Dr. Smith, not me, because we're doing the best we can. I mean, I'll tell you, our panels are huge because of, we just get assigned. But you're right, network adequacy is something that has to be addressed. It's the elephant in the room, I think.
Okay, so you folks are going to hate me. And because the prior authorization bill did go in front of the legislature, I was a member, was not a chair at the time, and we've heard all of the horror stories about the prior authorization, but we also heard from the insurance companies. And the reality is, we actually have a state statute that says we cannot increase our unfunded liabilities. What does that mean? State of Hawaii is the state is the largest consumer of health insurance premiums. We pay for all of the retirees, their spouses, all the state employees, county employees. If health insurance goes up, our unfunded liabilities go up. So whenever there is a request to cover more, we need to go through what we call a sunrise analysis to determine how much of an impact it is to state taxpayers to fund these unfunded liabilities, or how. Right now, we still have a huge unfunded liability, but they're hoping it would actually, because we keep decreasing the pool. You know, we no longer cover spouses. If you're a new state employee, you gotta pay for part of your insurance. It's not fully covered anymore. I mean, I pay for half of my insurance. So the pool coverage premium is getting smaller. So hopefully they were hoping sometime in 2030 or so, we can actually break even, and in which case then maybe we can increase coverage. I don't know. What I challenge you folks, because I agree that prior authorizations is a stumbling block to care. And that's the reason I voted in favor of having the task force. That's the reason when I was in the health committee, I voted to pass it out, okay? My challenge to you folks is that when you come to the legislature and ask for something, don't ask for the entire thing, which is a prime example is the GET tax exemptions. You know this. You folks know how many GET tax exemptions came through me? I had 15 bills. Feminine hygiene was one of them. Food all kinds of services, because they equate the general excise tax with sales tax, and we keep having to educate all these people who came from the mainland that moved to Hawaii. No, a general excise tax is not a sales tax. That's the reason why it's 4.5% versus the 15% in New Orleans, because if we start exempting, then we have to increase somewhere, okay? That's the reason why we haven't had a general excise tax exemption ever since I've been a legislator, ever, okay? Because nobody wants to raise taxes. So why this bill passed was, you folks talk to the tax foundation, they know we had to have a carve out specifically for Medicare, and TRICARE. We couldn't ask for all services. There was a bill asking for all services. That didn't pass. This one did. So when you folks ask for the prior authorization, and I think I've seen some bills, do it a bite at a time. Maybe for cancer of skin cancer, maybe for certain illnesses, okay? Because what I also hear, I mean, you folks are talking to the choir of other medical providers. You don't have insurance companies here, and you don't have, because in the legislature, we hear the other side. We hear about, and you folks know some of your colleagues would abuse some of these systems. They would farm it out to their friends and family, or whoever used to own a lab somewhere or other. I'm sure they have the ability to carve out the bad actors. So I don't really hear that, but when you start hearing about increasing the state's unfunded liabilities everybody else's state insurance. I mean, I'm hearing it from the property insurance side. You're telling me also our health insurance premiums are also going to go get higher because we're going to help out doctors, and we've already helped out doctors, and doctors already make 5 times more than I do. I mean, you know, this is what we're hearing. So that's my request to you folks, is I hear you folks regarding the prior authorization. One bite at a time.
I'd just like to respond a little bit to that. First of all, I think the senator's got some wise words. I mean, basically it's don't let the perfect be the enemy of the good. And that's the way we got GET reform done. We picked out those priority, that what was most important to, to the provider community and to their patients. And then we've got that through. I think it's important to kind of know that, that addressing prior authorization and making it better doesn't necessarily mean that you're going to have more care or that it will be more expensive. Often care that is indicated will just happen in a
Scott,
timely manner.
Can I address this a little bit?
Sure,
Because
please.
I was waiting. I'm sorry. So prior authorization reform doesn't mean we just don't do prior authorizations. So let's start with, I don't know how many of you are familiar with Avalon and what HMSA was planning on doing with our lab tests, but they were going to require that all lab tests were going to be reviewed by this outside business, this outside corporation that makes millions of dollars deciding if you ordered your lab tests appropriately. The hardest part of trying to accept that this was going to be a program we were all going to have to live with was when we said, well, okay, so tell us by which criterion you're going to decide whether we've ordered appropriately. And then they told us, well, that's Avalon's, wait, what is it? Proprietary information. So not only is everything subject to the rules, but you may not know what the rules are. So we could have legislation that says you have to tell us what the rules are. Also, in a related issue, we've had some transparency laws passed nationally that are not being followed in this state now. And, if everyone knew what was actually being paid, we'd have an easier time there. But going back to what prior authorizations were initially made for was so that you could not order something that would benefit you. So without a prior authorization. So orthopedic surgery, you had to prove that if you wanted to get paid for doing a knee replacement, you had to prove that that knee had been through physical therapy, had the imaging, had all of the things in a row, so that you did not make tens of thousands of dollars or whatever it is. Sorry, orthopedic surgeons, it's a lot more than I make. Don't get paid unless they prove that they need to do what they're doing. I don't get anything from ordering an MRI. I don't get anything from ordering Ozempic, which costs $5 to make and they charge $1,000 a month for. I don't know, that the injustice of the providers always being asked to tighten our belts while that's going on. Mavorette, one of the hepatitis C medications, costs more for the active ingredient than gold by weight if you actually do the math. It's all insanity, and at some point that gets addressed at a federal level. But going back to prior authorizations, we've been denied. Our friend Eric Murray has been trying to get the various insurance companies to tell us by which criterion some of their prior authorizations are made. And they've been denying him access despite the fact there are laws saying you have to tell us what it is, right? And then we can at least see, if it doesn't match up, if we are being denied things that the U.S. Preventive Task Force says we should be able to have, that we can show everyone that we're being denied unfairly, unsafely. So that's a bill we can ask for. That is a bill of just absolute clarity.
Yeah, that's an important issue I think a lot of providers have raised, is the issue of not knowing what the rules are. And for example, in imaging, there's the American College of Radiology's appropriateness criteria. They're vetted, they've got scientific research. They basically are revised constantly by experts from other fields with input. And basically it tells you, if you've got somebody who's got a sudden severe worst headache of life kind of scenario, then it gives you a choice of what are the most appropriate, tests that could be done. And it puts it in like a stoplight sort of thing, red, green, and yellow. So that's using national criteria that are transparent is critically important. Would be much more productive for providers if they could get on site and just see those right away. And that was one of the things that the American Medical Association model bill talks about. It's to shorten the time frame towards getting things approved with 24 hours for urgent requests and 48 hours for routine requests. The other is to automate the system so it becomes easier to use established peer-reviewed national criteria that are approved by medical colleges or other organizations. And then the other is to basically enable that those physicians, often these are folks that are highly trained with 3 to 5 years of residency, another couple years of fellowship. And then sometimes they're being second guessed by folks that are living in a state, New Jersey, whatever, by somebody that doesn't have the same set of skills or knowledge and they know nothing about the patient. And so this whole issue of gold cards, allowing people who have shown themselves to be highly competent in their field of practice to order without being basically checked every time is important. And I wonder, Dr. Okamoto, if you could talk to that issue.
Absolutely, yeah. Before I forget, Dr. Smith mentioned a very important concept, and that is having a certain kind of a bias in the way that utilization review is done. And let's just take Aloha Care. So we made sure that when we went into a pre-gold carding phase, that we deliberately selected groups of practicing physicians, many of whom are primary care physicians on neighbor islands, just to test out our informational model. And we just did a validation study about a month ago, and all those individuals who had done well as a group now, as opposed to an individual who may have a few prior authorizations experience from which to do a statistical analysis, as a group, they all did very well. And we just simply renewed their gold carding. But so it is a bias, and the CMS has required that all Medicaid and Medicare plans have a health equity analysis that's done on an annual basis with results that demonstrate that the health plan has taken those results responsibly into some form of action. So I think that's a very important concept. But I want to go beyond gold carding, because I think gold carding is more of a, not to be too pejorative about it, but it's kind of a Band-Aid reform of what really actually needs to happen. I think there is a reality that there are lower value, very high cost procedures that catch the fancy of physicians because of the situation they may be faced with a patient with certain unique features, or as a way of simply marketing themselves. And it's important for the healthcare system to catch those and challenge the provider for why they are requesting what might be called investigational or yet to be evidence-based kind of medicine that's very costly. Where the action needs to happen is at the point of contact that the physician or provider has with the patient in the office. And I know we've all talked about the promise of artificial intelligence, but I do think with greater closed systems of health information and the kind of applications that are now being developed, that there will be a time when a physician will have full autonomy in determining, with great transparency from the health payer or their own academy for that matter, or their own ACO, they will know whether or not the expensive test of maybe questionable scientific value can be approved for their particular patient and completely bypass the insurance company.
I think that's helpful, and I'm glad you raised your hand, Jack, because I was just going to force you to get up and come up and chat about this issue. So in one of Dr. Lewin's past lives, he was involved with these companies that gather healthcare data from multiple sources and then do an analysis. And this obviously offers the potential to drastically speed up these processes when they're required.
Yeah, there really are ways that we could use the technology today to literally, while the patient is in the office, tell the doctor that she or he hasn't really completed the workup needed for the diagnosis that's in front of them. And secondly, immediately tell the doctor and the patient, if that information has been correctly provided, that the prior auth is done before the patient leaves the office. But one of the things that really kind of I think is an opportunity is there's no state that said we're going to set standards. We'll get a board or a commission or something and set standards for what the prior auth rules should be based on the best science. So if we take cancer, we could say FDA plus NCCN. Nobody can argue with these standards. We could take for cardiac disease, we could say American College of Cardiology and ACHA guidelines. Okay, they change every year, but there they are. They're done, and so many. They're vetted by so many people, and we could move through specialties, and there we are. So everyone knows the insurance companies each does their own thing, and it's mysterious, and that's really the problem. You can't automate that. There's a mystery box in there. So I believe that some state, it might be a little state, maybe out in the ocean somewhere, could decide to really set up a body that sets the standards for the state that all insurance companies follow. They won't like it, but you know what? It'll be good for them, and it'll be good for the patient, it'll be good for everybody. Everyone will benefit if we follow the best scientific standards. Then step two would be, I'm, Dr. Lewin, and I'm not an oncologist, but if I was an oncologist and this particular cancer, I've tried everything, the patient's not in remission, and I'd really just like to try this new drug out there. Okay, but the patient doesn't have all the biomarkers and I'm tempted as the doctor to say, let's try it, okay? That wouldn't be able to happen because, you'd have to meet all the tests. And at that point, as the little small state in the middle of the Pacific, let's get involved in the clinical trials. So the people that are testing that drug or testing, let the patient enroll there and get that done. So I think there's a way to go, and maybe I believe we could lead the way in this one if we wanted to, because I think the scientific standards can be agreed upon, and we don't really need to have, the well-meaning chief medical officers of all the different companies make these decisions because it's too much for them to do. Quite frankly, it's just too overwhelming.
Thanks, Jack. I think we all agree that AI offers the possibility of bringing all the shareholders together and working together on these problems to cut down on the unnecessary delays and hopefully on the unnecessary denials. And that doesn't necessarily, again, that mean that there'll be more medical care, that often that'll be done in a more timely manner. And one thing I'd like to say too is that one aspect of the American Medical Association's bill is to say that if you're going to be talking to someone in the prior authorization process, that person that you're talking to is in state and they have a similar degree of knowledge and experience as the provider taking care of the patient. And I have to say that in my 30 years here, that when I call up medical directors, and I hate to say this, but a lot of them are my friends, I go out and have a beer or whatever, but I can call them up and I can talk to them and say, listen, this is what we have in our toolbox in Hilo. I've got this, this, and this. And I realize normally you'd want to do this, but that patient doesn't have access to that, and we don't have access to it. And we could almost always have a meeting of the minds and come to a reasonable decision on that. It's when you're talking to somebody with almost no level of experience in your field, doesn't know your patients, and they're based somewhere on the East Coast of the United States.
Yeah.
After you've waited on the line for 20 minutes, that's where the problem is. So that in itself could be a very helpful thing to try to bring these discussions back within the state rather than having them spread out through vendors who take their vig on everything and often don't provide, the value added as opposed to just trying to deal with these issues with their expertise within the state of Hawaii.
Yeah, Doc, I was gonna get that exactly because we were talking about AI and stuff like that. The value of AI, it's gonna happen. So a lot of us are like scared of it, but the reality is especially in rural areas, it has the potential to make a lot of good impact in the amount of the real-time care that I can provide because there's just so much that we're doing all at once. The key is data. So good data in, good decisions out. And right now, if we don't do our job and, the physicians aren't allowed to provide the care that we need when we're being overruled by not peers. And so I would say, you know, when it comes to prior auth, for example, if we could set standards, I know that's the hugest thing because I'm on all the threads, I hear it. It's that we're often being audited by algorithmic thinking. The person on the other side of the line is not a peer. So we are talking to somebody who is a checkbox, doesn't have any understanding of the lay of the land. And we can't have a meeting of the minds, and we can't come to a reasonable solution because it feels like it's basically just a no. So we're oftentimes calling and putting extra effort into a no. And we're just like, but you know, in other circumstances where we're able to speak to the medical office, so the chief medical officer, explain the case and explain why I cannot follow the quote standards of care because of the resources that are available, majority of the time it gets approved and we can push it through. So I think that's one of the key points is, you know, if you are able to talk about standards of care, it really is, you know, making sure that the people helping make those decisions are accountable to the right levels of care and that we have access to a true peer-to-peer, which, I mean, at Pittsburgh, I can tell you, we got into it a lot because sometimes it was our own physicians denying us care, but at least, you know, like you said, we knew each other. We could talk reasonably.
Part of the promise of AI and also part of the promise of regulating how prior authorizations happen could be one, limiting how long they can be. Sometimes this will be a 6-page form and they have no shame about asking you the same question on every page. Further, in this era of AI, why are we having to tell them everything that's already in the note that they're asking us to submit to them? I think that maybe more of the labor could happen on the insurance end instead of on our end. I'm actually using AI to get things passed already because I fed it some of the criterion by which things are passed, and it makes sure that if I'm trying to prove somebody has a rotator cuff injury, that I mention specifically that the liftoff test was failed, right? And I wouldn't have known that that was like the magic keyword that needed to be said. Just briefly on, this leads to fee-for-service, service, and how prior authorizations in some ways don't make sense here. Sometimes those forms ask me who I made a decision with, like, did you make the decision with a rheumatologist? And sometimes I don't behave very well and I write in very large letters across this line, there is no rheumatologist, right? So there could be limits to requirements for sign-offs like that. But very briefly on the fee-for-service thing, our hospitals are not trying to keep people inside our hospitals. Our hospitals, I even checked Oahu, are like, was it 89% capacity most of the time. And so anything over 90 is considered high occupancy. So we are close to high occupancy in those hospitals. And I know that we're at capacity or beyond, sometimes for housing, sometimes for rooms and sometimes for staff. But we're trying to get our people out of the hospital. We can't because there's no skilled nursing facility beds. Like, don't tell us that we're trying to keep people sick because we're not. Like, you can't apply that solution to us because that's not the problem. The problem isn't people providing too many services. It's not enough people to provide the services. So, basically, I'm saying you can make prior authorizations simpler, and I hope they do a better job than some of the programs we're asked to use now, where, for example, you get asked every year to document why you didn't do a pap smear on a woman who had a hysterectomy. And every year you have to go back in and document that they didn't have a hysterectomy. That is the level of software our people are being asked to deal with now. It doesn't really seem like they're investing in saving our time so we can spend more time with our patients and less in front of our computers.
Well, we probably have some other issues. Yes, please. You have a question for us, or?
I'm just thinking about lawyer in California, and we often challenge the state on issues like this. And I always viewed it as a cost-cutting device. And then hearing Senator Ventura say that if we eliminated it or we cut it back, big cost item. So it is a cost item. It's a control, internal control of the insurance company or state, whoever is in that role, has to limit their liability. They have no negative incentive to themselves to do that correctly, right? That's the problem. So they can say physicians have to do it correctly, we're going to value the patient. But if they make an incorrect decision to prior authorization, there's no penalty for that. And that is a huge problem. And I think we need to look at this as a cost-cutting device. That's what it is. It's not a oriented, at least that's my understanding. You guys can correct me if all folks more experienced in this myself. But it's not geared towards quality of medical care or quality of care for the patient. It is geared towards saving money for insurance. And I don't think I'm going out there. I think that's exactly what's happening.
You're right. And honestly, so I'm one of the last physicians on this coast doing work comp. And a lot of people don't want to do work compensation. And the reason being, it's mother may I. So I see the person, they have an injury, I know immediately what needs to be done, but I need to submit 1 million treatment plans and wait for the adjuster, someone who's not medically inclined, to give us the approval before I can schedule anything. Some legislation's passed so that we can stat approve certain things when we think that there's a neck injury or back injury, stuff like that. But I was telling my colleagues who don't want to do work comp, I'm like, you've been doing it this whole time. Primary care has become mother may I work comp. I mean, we are constantly asking for permission. And you're right, that's part of it, because from the business side of things, when you're looking at work comp, it is to try and, limit the cost to the employer and to the insurances, right? So they're coming at it not from a quality perspective, like that's my job, right, to kind of prove and I fight. So like every single work comp note is delays in care have resulted in extended disability period. This is certainly impacting the patient's course of care. I mean, because at least from the work comp perspective, we are delayed months at some point. But I think you're right. It is, the prior auth is the equivalent. And so the thing is, people can't opt out of that side. Like a lot of my friends no longer do work comp because it was so much, but they really truly can't opt out of the prior authorization part of things because it's what we were trained to do. We were trained to do this primary care. And so like overthinking it and then putting the burden, basically the proof of care, right? So it's like you're guilty to proven otherwise. It's unnecessary until proven otherwise. And I can say with certain insurances, it's like that. Like, going in that we have to more than make the case. And that's actually discouraging some of my colleagues from taking certain insurances. And I don't like that we've officially become more of a tiered care society. Like let's look at what insurance they have first. That shouldn't be, we should be able to just apply the same types of dignified good care to everybody regardless. But I will say that a lot of my colleagues, and I respect them so much, but they do have to take that into account. Like, ugh, I don't know. I don't want to do mother may I medicine anymore. Maybe DPC or something.
Just a point of clarification, at least this is the way I look at it. I would discourage us for equating prior authorizations with insurance companies. So if you had a magic wand and we eliminated insurance companies, any physician, provider, organization that took on full risk, or even just shared savings, or any of the alternative payment models that Eric Schell and others discussed, would need to have some kind of a mechanism by which to create guardrails against what they would feel are low value, non-national standard type of procedures or treatment. It may be called something quite different from prior authorization, but that function will probably still exist.
I'm going to confess that I do, and then we're going to take the questions that I just saw out there, sorry, that I practice in ways that are outside of guidelines on the regular basis. So I will have a patient come in and they'll have a hemoglobin A1C. That means they have diabetes, not terrible, but they have diabetes and their A1C is 7.5, right? And I know that this patient really does not want to go on medications and they're motivated. And so I don't start a statin right away, even though they meet the criteria, they have diabetes and their cholesterol, their LDL is over 70. Statin today, right? And instead, I turn them loose to go work on it for 3 months. Or even better still is when they come in and their A1C is not quite diabetes, like it's 6.4, and we have a dietary intervention. And I want to tell them that we're going to check again in 3 months because I want to show them that they've been able to make a change. But it's not covered. Under the Avalon rules, a person who did not qualify as having diabetes, at the earliest they could repeat it, I think it was 1 year, to get an A1C. And that's what I'm trying to say is like, I want the system as much as possible to trust my judgment that I know what's going on with my patient. That questions out there.
Taking on new work comp patients. And I'm a kapuna. I'm not afraid to admit that. And I just was told that I could be on a committee with Dr. Miskovich and another state senator, I can't remember his name, to put forth some bills for the legislature in the January session. So I am taking to heart what you said about not asking for everything and to prioritize it, but I truly hope that some of these bills will be passed because the delays and denials are horror. I just hear horror stories every session, and I'm talking about people with amputations that can't get correct care, people especially with head injuries. So if there's anything that you can impart to me that will hopefully get the legislature to hear these bills, I would be very open to hearing that.
You know, we've had a very good conversation on this, and we do have some other issues to go through here. But clearly we have a problem, not just in Hawaii, but the United States. Senator Hirono sent a letter to Dr. Withey that she shared where the senator was saying that she and other congressional representatives have written CMS and Health and Human Services directors and said, listen, we've got a big problem for America's elderly. We've got to fix the prior authorization issues for Medicare Advantage. So there's solutions being sought at both the federal and the states levels. As Dr. Okamoto noted, we're probably 20 plus states have introduced legislation. That's a process that I think it's timely we should look at. But I wasn't being flippant when I asked Congresswoman Takuda if there wasn't some way that either on a congressional basis or a state basis that we could, in effect, declare a state of emergency, especially on Maui, you know, where they've lost multiple clinics and they have a severe shortage. We need to get our existing providers on Maui and the HIPSA areas as productive as possible. And when there's, for example, the state has put together I guess when they're looking at cryptocurrency, they created a digital sandbox, you know, to explore that. What if the county of Maui, including Molokai, where Dr. Akio Nadang practices, were to be, in effect, become a sandbox? You know, where you would say, the mayor, the city council, the legislature, we want to put together, how are we going to do it? But, with some adult supervision from a government agency, I would suggest Dr. Lewin, but we get together and get all the players together and figure out what can we do to address the prior authorization issues, maybe rather than a blanket moratorium on that issue, find some way where there's severe shortages of providers to address that problem now, not next year, not 2026, but now, because now is when people need it. So that's just something to think about, please.
in Hawaii, there's very little accountability for the insurance companies.
She's not white.
Provide care. And it's very disheartening. So this needs to definitely be addressed soon now because it deteriorated greatly over the last few years. And I can't handle all these visits. I have to be elevated because I'm going to all the patients for other islands, especially Oahu.
Well, thank you for that comment. Yeah. And so basically, you know, Hawaii's been a leader in healthcare in the past, especially in making sure that insurance is expanded to as many people in the population as possible. The point's been brought up. We've got good insurance coverage in general. Let's make sure people have access to healthcare providers. And so I think that's a worthy goal. With that, Dr. Don Sands, I'd like to invite him up to the Hawaii Dental, where he's got some issues that perhaps would bear some consideration by our panel or our audience on the issue of oral health care.
Thank you, Dr. Scott. And Senator Joy, you were right. She runs her organization very, very tightly. I was reluctantly brought into activism, advocacy. I thought it was activism, so I shied away my whole career. But the first time I did try to speak, it was in her committee in 2022, when the reinstatement of adult Medicaid was being championed by a group. I was a co-founder, Hawaii Oral Health Coalition. Same year, I started another group that was doing outreach to Native Hawaiian villages, which is Hawaii Dental Hui. So I'm going to give you the 4 priorities that the Hawaii Dental Hui have for this session. But back to Senator Joy. So I'm like the half of you guys in the back. I don't like public speaking, and so I spend my whole career just talking to patients. Cosmetic dentistry in Palm Springs was good to me, but it left me depressed after 15 years. Depressed enough to sell my practice and go to Calcutta and spend time with Mother Teresa. It started changing my thinking. Maybe dentistry could be a tool. So fast forward to 2019, the CEO of my FQHC said, half of your friends can no longer get dental work care. I said, what? I mean, my friends are who I love and we're making their health come back. And he said, no, we're not going to do sliding scale anymore. So the next month, I spent all my time on the internet studying public health in Hawaii. And I found out the kids' oral health is the lowest of all the 50 states, United States. And we started Hawaii Oral Health Coalition with about 30 stakeholders. But then, you know, like Forrest Gump, the movie, all of a sudden I found myself in really weird places running to the WAM committee because no one else is going to show after COVID to ask for 16 million more for the adult Medicaid. And my heel came off. I had to walk in and, what's his name? What's this senator? Donovan, he's like looking at me like I have a limp. But I was dragged into this, and in Senator Joy's committee, my hands were sweating. They were like I was crying out of my palms. And I was getting coached by Dr. Joe, and he said, okay, stay on script. Every time you go off script, you're going to lose the audience. And then I started talking about my great uncle, Joe Itagaki, who was a senator during the territory. And Joy says, okay, time's up, Dr. Sand, get to the point, sit down. So I went home and cried. I didn't really cry, but I thought, this is not, the bill passed, and I was sitting there front row when Lieutenant Governor Sylvia Luke said, congratulations, you guys got 10 million. I'm like, can I come to your office? So at the end of the 10 days, we got 26 million. So I found myself in these places just like I'm here. I wouldn't be here if it wasn't for Dr. Scott and Dr. Jack, who just texted me 3 days ago, hey, we're doing a cool thing. So now I want to look at and talk to you guys. I think in this room, especially in the second half that's not talking, there's enough brains to figure out these things we're all talking about, and there's enough heart to reform healthcare, not only for dentistry, but medicine in Hawaii, but we got to stick with it. It's going to be not just this conference. So I recommend you join these groups and then show up to the health chairs, both the Senate and the House. Share your voice and then stick with these nerds who write these white papers and the research. And I give for the GET tax, even when we went against the state Department of Taxation, by their own estimates, they said, you guys are trying to take $900 million over the next 10 years. But we did it, right? So it was from people like you guys all working together with the guys that did the work. So what are the priorities this year? Well, we passed the law for reinstated adult Medicaid, but since the benefits started last year, nobody's getting care. So we activated 300,000 of the lower income people in Hawaii. 70,000 are Native Hawaiians, and there's no dentist to see. In fact, they don't even know about it. And I think, Noel, there's a little bit of what you were talking about going on. So the money's there, it's getting spent. We haven't even seen where it's going. So we want to, Hawaii Dental, who's about 35 private practice dentists, we want to do something this year. At the same time, have a 2-year, 3-year, 10-year plan. So what we want to do is deploy mobile, because we know with modern prevention, we can go to the communities, we can bypass social determinants of health, and we can, using modern dentistry, we can see 3 times as much patients if we do some of the modern stuff like no drill, no shots. So each dentist, hygienist can see 3 times as much patients, but let's go to them. We can integrate oral health, behavioral health, and medical health in these innovative models. So we want to do mobile. Our safety net is the FQHC. People are bringing it. FQHC, we're thinking, oh, it's federal, they're good. But no, the FQHC's first appointment on the average of the 14 is a 10-month wait list for these patients. That's why they're not getting care. So that's not including the 4 or 5 treatments they need. So the easiest thing is us state and us private need to invest in the FQHCs. They're the fastest ones to scale up. And the last one that I was going to talk about is prior authorization. Senator Joy knows the one we're talking about. It's a nitrous rule change. And I'm not going to go into the details other than if we don't work together, there's going to be thousands of kids not getting care. They haven't been getting care since April 1, and they won't get care for the next 10 years. We'll have a lot of dental phobics. So anyway, I try to keep it to 4 minutes. Put in my story, what is Hawaii Dental Hui? What is Hawaii Oral Health Coalition? They're basically clubs, and you guys can make your own clubs or join these clubs, and there is power in numbers. Thank you.
I appreciate one of the nice things about the last couple of years is that, we formed this task force and we have doctors and dentists and APRNs and we just have a group of folks that work together and kind of put our shoulder to the wheel. And that's been made a lot of friends that way. And so thank you for that. The one thing that I will kind of mention too, in addition, we had this huge victory on the GET tax. Hawaii remains one of the 2 states in the country that broadly taxes healthcare. And it's absolutely fantastic that we've, for Medicare, Medicaid, and TRICARE, we're going to expand access to care for those programs. We're hopeful that when DOTAX takes a look at the cost of that they've vastly overestimated what that will cost, and that the actual cost will be significantly less. And Dr. Withey has done some work on that. And if that proves to be true, hopefully that amount of money that the legislature has already agreed is that they've committed to the passage of SB 1035 could be applied to allowing those on private insurance plans also not to pay the GET tax. Because as you know, if you've got renal disease or cardiac disease or cancer treatments, and you've got to pay that additional 4% or 4.7% with county surcharge, every time you go in over a course of a period of years, that could prompt you to abandon therapy, and nobody wants to see that. Dr. Okamoto, Senator San Bonaventura, any closing thoughts for us?
I just want to mention a couple things. I feel for you regarding workers' comp. I used to be an attorney representing plaintiffs for workers' comp, and it was super difficult then. I do want to point out, though, that the workers' comp statutes is different from regular healthcare statutes. The types of prior authorizations you're talking about is far more significant, and I believe that's probably the labor chair. And I see Lauren Kim always raising his hand, and I really do want to call him because I think we really need to hear from Department of Health. So Lauren, what is it you want to talk about?
Hi, I'm Lauren Kim, the Policy Director and Strategic Planner for the Department of Health, and have a quick comment, a recommendation, and an invitation. So the comment is, I really appreciated the mention of network adequacy. It's not just network adequacy, there's also a patient bill of rights that's on the books, and who's doing what to enforce it. Quick story, the legislature gave my office $2 million to fly patients from Molokai and Lanai to Honolulu and Maui, and providers to Molokai and Lanai, and I opposed it. And I said, I can understand for Medicaid, but this is a subsidy to for-profit or for private health plans whom EUTF is already paying for. And I was just told, don't go there. And I argued network adequacy, and that you said, don't go there. We're at the point where, mothers giving birth from Molokai, and I think we all know that case, barely are having a successful delivery. So it's just about human health and safety. So we're implementing that project now. The recommendation is, we talk a lot about prior care. I was sitting in Jack's office when he talked about a community hui that uses evidence-based open standards. It's not just laws and cajoling people, but the Inflation Reduction Act for the first time allowed the federal government to negotiate with pharma. So remember that EUTF is the largest purchaser of healthcare. And I was sitting in Kenny's office, my boss, and we talked about in Jack's office how there is no health advocate as a trustee. I know they have access to Milliman and Robertson and healthcare consultants, but there's no health champion, nobody with an MD and MPH and APRN on the EUTF's board. They're all well-meaning. Current DHS chair is there, who is a former health chair, but that's an opportunity to flex the muscles, the combined muscles of the EUTF and Medicaid when the RFP for these managed care organizations go out. So just reminding you that there's that other lever. Everybody wants state business. We are the largest purchaser of healthcare, and it is a creature of budget and finance. I'll leave it at that. It's attached to that agency. Yeah. And the last is an invitation. I was given a task by the Director of Health, whom you may know as Kenny Fink, former Medicaid director, all-around brilliant guy, to make the lives of healthcare providers and patients easier. So thanks to people like Aloha Care, who came out in early and strong support, and thanks to the exactly 59 seconds I had in front of Chair Sanventura's committee, she helped pass SB 3139, which is Public Health Standing Orders, which is an attempt to relieve administrative burden by, and this is, we are authorized to work with the private sector, in this case, for anything with USPSTF A and B recommendation for a patient to self-refer. So why does a woman need orders to get a mammo that we all know that she needs? Devil is in the details. We know this. You don't want somebody getting 3 mammos a year, CLIA standards and all those. But if it's USPSTF A and B, then you ought to be able to self-refer and improve secondary secondary screenings. So, but the invitation I'll make is, Dr. Fink has laid that on the table that it's time for the Department of Health to reassert itself in health policy leadership. And that includes not just public health, but health care. So to the clinical psychologist, my advice to you is get the assistance of a state agency. We automatically get an audience in front of our subject matter chair. It helps when the state of Hawaii logo is there. I can't guarantee we'll support you, but I get paid to do hand-to-hand combat at the legislature. So talk to your Department of Health. I'm inviting you to talk to the Department of Health, providers in this room, so that we can together figure out how to reduce administrative burden. It is a priority for Dr. Lewin, it is a priority for Dr. Fink. The governor has been generous with the loan repayment, and it starts there, but it can't stop.
No.
I was talking with, the last comment I'll make, I was talking with my old boss, I'm a managed care hack back in the day, Rick Chung, and he's with Hawaii IPA. And I told him, what are the things, how could the state lead in making life easier for patients and providers? And he actually did the math at Hawaii IPA. For every 8 hours of seeing patients, a provider has 9 hours of paperwork. Some of that is done by the medical assistant. Some of it can only be done by the provider, like charting. A lot of it's prior authorization. And prioritization will never go away, to Dr. Okamoto's point about if you're full risk, you need to make sure the guardrails are there. But I think Jack is onto a great idea. So I'm inviting you to knock on my door to see how the Department of Health can facilitate these conversations and lead them from a policy standpoint. If we're going to make change in Hawaii, it's going to happen under chairs like Chair San Ventura and a physician governor. We cannot waste this chance. So thank you, Chair.
So thank you, and I'm going to make it really short. Otherwise, I would have cut him off already. Whenever you come,
You have 1 minute.
yes, I have the mic. Anyway, if you come to my office regarding legislative work, the reason I cut you off more than half the time is because I already read the written testimony. So submit those written testimonies in. And the second thing I want to talk about is network adequacy, because, okay, we do a lot of balancing, and HHSC, at least on this island, has done a lot of recruitment of specialists and the like because of the lack of network adequacy. The problem is now we have a public agency competing with private interests. And the biggest problem, and you know this, Dr. Scott, is Pacific Surgical, right? When we start having these, there's this balancing that the chair and the chair, and when I talk to Dan Brinkman, whenever he wants to ask for more money for certain things, I gotta think about what about our private physicians, the people who in the Puna Hawaii, the people who've set up with their own private monies, their health centers. Why is public money competing with that? The urgent care centers that they've already set up why is HHSC competing with that? And this is the kind of thing that, for some reason, certificate of need doesn't affect HHSC. Now, I don't know why, okay? But that's another thing we have to think about. And I'm gonna let this go, but the reason nobody complains to me about my 1 minute is because I treat everybody equally, even Department of Health. So thank you.
Let's give our panel a big round of applause. Thank you so much. And thank you, Dr. Scott, for moderating for us.